Hello. Can everyone hear me? Can you hear me? Yeah. Welcome everyone. We might make a start. We might make a start. Can you hear me? Yep. Okay. My name's Rebecca. I work with Partners in Recovery here in Launceston and in the Northwest. And I'd just like to introduce the presenters for today. So they're all from Inner East Melbourne PIR in Victoria. We've got Corey Hoare, Daisy Gleeson, Stephen Webster. So they're going to talk to us today about microsystems change, what's possible for an individual.
I don't know whether I actually need a microphone because I'm really quite loud. So, microphone. Can we maybe we could move that naughty table there? They could probably move a little bit closer. I kind of like having a microphone though. There's something about it. I've always fancied myself as a karaoke singer, and I was on a cruise about 3 weeks ago, and they had a karaoke tournament, I think. No one would let me sing. No one. And there were some particularly terrible people, let me tell you. But for the sanity, you can't get off a cruise. So it sounds like we've got a noisy group today, and that's good, because noise and conversation usually leads to ideas, and ideas lead to improvements in practice, and improvements in practice leads to better outcomes for the people that we support. So, as I said, my name's Corey, and I'm a service manager for Inner East Partners in Recovery in Melbourne. Some of you know PIR, some of you don't. Inner East PIR is one of the larger PIR regions in Australia. I have a team of 17 people. So I have 14 support facilitators, I have 2 senior practice leaders and myself, and I have a Chinese program worker, and we represent half of our region. So in total, I think there's about 34 staff in the Inner East Partners in Recovery region, and we have a third-year target of 660. Currently, we will meet that in October. We've been getting a conservative average of 30 referrals a week, and in April we had 90. So it's been a fair bit of learning about, how do you manage such a large and complex and diverse caseload. And it's fair to say that I'm probably not telling anyone, but the people that we find and support do come with some fairly significant challenges in their lives and some fairly complex systems that go around them. I went to recently, they're leaving already. Oh no. I'm actually diversing, but I went to a care team meeting that had 25 agencies present for one consumer. So that was interesting, and in a way that was a little bit of system change. So PIR's had this mandate about systems change. We want to improve things. We want to make things better. And a lot of the time when I do induction for new staff, it's all about, what's this idea of systems change? What does that mean? And is it really big? And when we see things like this, we think systems change in PIR is a really big thing. Has to be big, has to be complicated, has to have a lot of people involved, and it has to cost a lot of money. And I say to people, well, I don't know whether I think that's necessarily the right way of interpreting it, but the assumption is out there that it's bigger than me. Systems change is slow, it takes time, and it's a really, really big process. And there are lots of things that need changing, and they will take lots of money. But I think what we tend to forget is that we work with individual people, and we support consumers to make changes in their worlds. And we don't often sit back and think about the changes that have occurred. But it's always sort of made me think that my own life is also a system. So when I make a positive change in my life, I'm actually making a positive change in my system, or effectively changing my own system. And I'm changing the way I think, I'm changing the way I respond, and to me that seems like systems change. So if I think about my own story and my own things about system changes, I have a lived experience of illness, and recently, well, a wee while ago, I did this facilitator training for My Recovery. Great program if you guys are interested in looking at an intentional peer support-based recovery support program. My Recovery is fabulous, great outcomes. So anyway, I'm sitting there in this training, and we're doing all this training, and I tend to get a bit nervous, and I'll go, oh God, it's a bit messy over here, and I'll tidy up. And I was sitting there, and I thought, why do I do this? Why every time when I'm anxious and my OCD gets a bit going, why do I start cleaning up? And it happens in the strangest places. I do a lot of presentations at clinical care teams and at hospital boards and all this kind of stuff, and I sit down and I have to really try hard not to pick that cup up over there. And during this training, it dawned on me, like, why do I do this? Do I have to? And at that moment, this light bulb went on in my head, and I said, I don't have to do this. And I just all of a sudden affected this change in my life. So I've affected my own system change. So when we think about the lives of the consumers or the people that we support, we're really supporting micro change in people's lives. So it's not just at a personal level. I've actually got myself a little bit lost. It's not at a personal level. It's not just at a personal level that we can make micro changes, but we can make micro changes with our partners. And that's around this idea of when we participate in a care team meeting, if we model good person-centred practice, we model good language. So when we start to talk about Johnny lives with and Johnny manages, Johnny doesn't suffer. So we get this idea of changing the language and demonstrating a language change to a clinician. So I sit down with one clinician and we talk about Johnny, and Johnny lives with and manages the symptoms of his illness really well. He doesn't suffer from it. That one clinician has 20 on their caseload. So that one clinician takes away this idea that having a mental illness isn't always a bad thing. I cherish mine. It's part of what I'm about. It's what makes me me. So I just live with it, and it's only this tiny little part. But when we affect the change for one clinician, he has 20 consumers, and all of a sudden, he's changing his language. He's not labelling, he's not blaming. He's changed the way he works. I've affected some change in his life. I've fundamentally improved a system. That clinician goes to a clinical review, and there's another 10 clinicians. There's a psychiatrist over there, a registrar over there. And this clinician starts to talk about supporting someone to manage their illness. And another clinician thinks, gee, you're a bit weird. What are you talking about? And what do you mean that, a change in the way we use language can affect how the people we work with respond to us? So clinician number one has a bit of a chat, and in our case we have co-located support facilitators in this clinical team, and I have a bit of a habit of soapboxes, and I get up on there, and language is one of those ones that costs nothing. Costs nothing to have good recovery orientated language, but it means so much to the people that we support. It means that we recognise the value, we understand and we listen. We don't blame and we don't judge. So the next clinician, he's got 20 clients as well. So he starts to improve his language. So now we've affected change for 40 people. We haven't spent any money yet. All we did was change the way we talked, change the language that we use. So in that clinic, I think there's probably upwards of, let's say there's 10 case managers. So we get 10 case managers that start to use better language around working with consumers. 140 consumers are benefiting from that. I'm not sure in Tasmania, but the caseloads turn over quite regularly. So those 10 clinicians had 20 consumers each. Did I say 20? 20 consumers each for 3 months. So that's, say, 200 people. 3 months later, another 20 clients each. So this idea of affecting change that's only tiny, we have a micro change in language, starts to become a macro thing. And it starts to get bigger and bigger and bigger over time, because clinician number one, he decides, well, I've had enough of this gig of being a clinician. I'm going to go off into the community mental health sector. So off he goes, and he continues to model that good language. He continues to talk about people managing, talking about living with an illness, instead of this idea of sitting in a care team meeting and having to listen to a clinician say the only reason that guy's any good is because we jab him with clozapine. You know, I really want to swear every time I say that, and I've actually managed not to. But bloody hell, you know? Talk about dehumanising. So we go off and me being me, I sit this guy down and I say, you can't talk like that. Why not? I've talked like that for 40 years. Well, you know, times are changing, you need to change. So again, just one conversation about jabbing people with clozapine is not helpful language. You know, maybe at the moment I'm not well enough to really grasp the concept that this treatment might really help me, but when I'm being stigmatised by language by a clinician like that, you know, it's not going to endear me to want to participate in my journey. So this idea that we can start with a little seed that cost me nothing, cost me half an hour or an hour in my team meeting to go through all these ideas of language, and they all escape me now. Can't think of any other examples other than that one. But there are lots. And it's this tired language, the language we hear all the time. Oh, just get out of bed. Well, it's not that easy. So what we thought we would talk about is, what does that look like from our point of view, from the perspective of a service delivery, for this idea of affecting great change from a small thing. I think the little quote that comes up, and I always get it wrong, is from acorns oak trees grow, and it didn't cost us anything. So we had a bit of a think about it, and I by no means am an expert. I'm not the fountain of all things worth knowing. I'm just, you know, a middle-class white farmer's son from New Zealand. So this is just a way of us perhaps sharing some of the ideas that we have, and perhaps listening to some of the ideas that you guys might have, because we in the Inner East at the moment have been caught up in this whole PHN thing, and you guys are really fortunate. Can I tell you how fortunate? And it was during yesterday's chat, I heard this, it was like, what do you mean you just have one of these things? You've got this little island and you just have one system in the Inner East. Inner East Medicare Local, East Medicare Local and North Medicare Local all put in a bid to become the PHN. And part of that is that we now have a significant slice of a rural community. And inner East Melbourne is the suburbs of Box Hill, Manningham, Boroondara, and the city of Whitehorse. So quite affluent, quite urban, suburban, I don't know, but lots of services, lots of money, lots of people, lots of diversity, but we have no experience of this idea of country folk. You know, I think of country folk and think of people playing banjos. And so part of the reason we come down here is we wanted to learn a little bit about how do you do service or system reform when everything's so far away, it's so disjointed, there's so much distance. And I keep coming back to this idea of one person, changing one person's attitude at a time, and this cumulative idea of change from micro to the macro, and it still hasn't cost us a cent. So what we thought we might do is, eventually shut up. I told you all, once I get this microphone, once I get my anxiety under control, I get going. And I got a bit of a shock yesterday, you see, when Helen was chatting away and she said, "Do you empower people?" And I thought, yes, God, I empower people. And then she talked to my language. And I sat there and I had the biggest panic attack. And I'm still going. So you need to forgive me if I have a tendency to ramble. But what I thought I will do now is I will introduce young Stephen. Stephen's been with us since the beginning. Recently we've had a change, so Stephen's now has this great new title of Senior Practice Leader, which effectively means he does all my work that I didn't want to do anymore. Yeah. I don't do the operational things, I do the lunches. Yeah, I get up and talk, and they can do supervision. Supervision. So without further ado, I'll hand it over to this young fella.
Thanks for that, Corey. Well, thank you all for sitting through that wonderful introduction that Corey's given us all. Look, I thought I'd get up here and maybe give a bit of an idea of what this actually looks like in practice, because I think the idea of microsystems change is one of those kind of, it's a bit of an airy-fairy kind of word. It's one of those things where we can kind of get a bit, oh yeah, well that sounds okay, but how do I actually do it? Because I think it's something that anyone can do, and that's the beauty of it. You don't have to have $1 million budget. You don't have to do a big conference. While all that stuff is great for systems change, this is something that individual workers can do. This is something that carers can do. This is something that consumers can do. This is something that students can do. It's anyone who wants to start making a change. There's lots of different ways that you can do it. And I think it's really, at the end of the day, it's about making change from the ground up, not this top-down, big organisational government, slow decisions, all that kind of stuff. It's about modelling behaviour, and it's about really kind of that whole be the change you want to see thing. So the example I was going to run through is the changes that we've found with our clinical services, the case manager partners that we have in Inner East Melbourne. So, it was nothing really that revolutionary that we did. We have a number of staff co-located, so they spend their time at the offices of the major clinical mental health services in Inner East Melbourne. And they're doing, things like building relationships with them, demonstrating the value of new ways of working, of, sharing those success stories with them within their office on a day-to-day basis. They're attending the clinical reviews regularly, and they're helping facilitate referral processes. But one of the big things that I think was kind of thinking about as a really good example, and it came to me yesterday when Helen was speaking about how they were trying to bring in one of these major clinical services this idea of nothing about me without me is for me, and how it took this big management change from the top to decide that we want to start including the people that we work with in our decisions. And that was what I really thought about as one of the big successes that we've had. Sorry, I gave you a little bit of a sneak peek of what Daisy's going to talk about. So when I first started working in Partners in Recovery in late 2013, I remember trying to organise a care team meeting. So trying to get everyone working with a person and them and their care around a table together. And pretty much universally hearing from one of the particular clinical partners that we had, we can't invite the person to this meeting. What will we be able to talk about? We won't be able to be open. All these kind of objections about basically inviting someone to be a part of the conversation about what happens to them in the future. This nothing about me without me is for me thing. And I think through a lot of the stuff that I mentioned on the slide, a lot of building relationships and really showing our way of working and organising our own care team meetings, inviting clinicians to come along to care team meetings that involve the people that the meetings are actually about, and showing a bit of that value, demonstrating that it actually works and how much easier it is. I remember having this moment, it was like that light bulb moment. I think it was in about February this year. I was sitting in a care team meeting that at the last minute, a client of mine wasn't able to attend. They'd been held up, for whatever reason, I won't go into it, it's a long, boring story, but they couldn't actually attend the care team meeting. And in this meeting was a team leader from one of the major clinical services that only a year and a bit ago had been saying, this is too hard with the people present. And we were talking and we were coming up with these ideas for what we might be able to do, and the clinician's gone, this is really hard without, I'll use John as the name, this is really hard without John here. I don't know whether that's going to work because we can't ask him. And it was this light bulb moment, like this is a team leader from a clinical service who 12 months ago did not have this concept of having people present for discussions that impact their future. It wasn't even on the radar. It was really heavily, it was more than not on the radar. It was actually really strongly pushed back against when it was brought up. And within a year, through nothing more than a couple of our guys who spend a bit of time at their clinic building relationships and showing other ways of doing things, and I'm sure a lot of conversations about the reasons why we do it. One person co-located a clinic and suddenly a whole team of people, a whole team of case managers are starting to take on this idea of including the people who we work with in the discussions that impact their future. It didn't have to be something that was a big top-down, government decision. It didn't have to be managers dragging case managers kicking and screaming. And I'm sure they're not all doing it just yet, but it's one of those things that it starts to have a flow-on effect. So one case manager does it and starts noticing, and then they're in the lunchroom and someone's complaining, I can't get Bill to do anything. And it's like, well, have you asked Bill whether he wants to do it? And that idea starts to spread and people start, colleagues talk to each other and other case managers start to do it. And that idea that Corey introduced, where it's a case manager has 20 consumers on their load and that changes over every 3 to 6 months. And it's I guess this idea of what is the mental health system apart from a bunch of workers, a bunch of carers and a bunch of consumers. There's no formal system really around it apart from, some people get their funding from state government and some get it from federal. So we don't have to have this big top-down thing all the time for a systems change. It's great when that happens, but as individuals, there's not a single person in this room who can't start that conversation and start those dominoes falling over and start working towards this idea of systems change. So I'd like to introduce Daisy now. She's another one of our senior practice leaders, and she's going to talk a bit about some experience that we've had with a system that I'm sure everyone's nice and familiar with, which is Centrelink.
Okay, so first of all, I'm probably not going to be as eloquent as my colleagues. I get very nervous. So everything Steve and Corey said, I also say. So Centrelink, when we first hear about Centrelink and we think of them, there's usually just a collective, Centrelink, They don't listen, I've got to be on the phone for an hour and a half before I get anywhere with them. They're not really listening to my whole story. They're just, it's all about money. So what have we done with Centrelink? Well, from one relationship, so this is one of our local Centrelinks. From one relationship, so Corey has a relationship and has built a relationship with the regional head of social work for Centrelink. He developed that relationship. They worked over time. And from that, they decided, let's do a co-location at Centrelink. Let's put some of our partners in recovery staff in the Centrelink office. So In doing that, Corey spent time, and the rest of our team has spent time in building relationships with Centrelink. And throughout that process, we tried to demonstrate value. You know, what can we do for them? How can we make the process for Centrelink social workers easier? You know, what can we do that they can't, and that, you know, they get people coming to them going, you know, I've got this, and this, and they've got nothing to refer them on to. So they call us. They ask us for advice. We ask them for advice now as well. So we were demonstrating our value. We were demonstrating how we can work together in collaboration as a team. We shared our success stories and our recovery stories with them. We showed them what was possible, and they also told us, you know, where they were having difficulties and what their barriers and their boundaries were in their work. And that was fantastic because we've been able to work around that and form new relationships and new ways of working. And one of those ways of working is our facilitated referral process. So with our we've got 3 staff located at Centrelink for 3 days a week, so 1 day a week each. A social worker will see a client at Centrelink and they'll go, hang on, something, you know, I'm feeling like this might be a bit bigger than, you know, maybe what they're telling me, or that they've got more of their story to say. They'll call over one of our support facilitators, and our support facilitator will sit down with that client, sit down with that person, find out what's going on for them and take a referral. If that referral for our program isn't, you know, maybe they don't have the complex needs that we need for the eligibility, we will then refer them on to another program. We will refer them on to what is appropriate, that no wrong door policy. And Centrelink see that, and they see, you know, the value and what we've got to offer. And we've also started to see the value in what Centrelink have to offer. Press the next button. Okay, so what has been the result? Through our conversations and through our learnings with the Centrelink staff, we've been able to develop, we've been able to encourage and work with Centrelink to become, as a whole, more person-centred and collaborative. They all know who we are at this office. They see hundreds and hundreds of people every week, and they're now thinking about, hang on, what else does this person need? You know, what else could I be doing to support this person in their life, in their journey? It's no longer just about engaging people with DES providers, so disability employment services. It's about thinking a bit more outside the box, and that's fantastic. And now mental health and other support services are actually being included in the discussion. So we've been brought together. It's not just Partners in Recovery anymore that's being included in the discussion, it's other agencies as well. So what started as one relationship, one contact, has affected, I would say, hundreds and hundreds of workers. And imagine how many people they are affecting in the community. When that person walks into that Centrelink office and goes, I'm not okay. You know, I need some help with a payment. I don't know what's going on for me at the moment. Instead of them just going, well, look, this is the procedure. This is how you need to fill out this form. They're stopping. They're listening. And they're thinking about what else they can do. So from what Stephen said before, it wasn't that top-down approach. We've had that seed. And that seed so far has grown into a massive, massive oak tree. And it's soon to be, from what I hear, maybe even growing further to other Centrelink offices. They're taking this idea with them. They're promoting it to other people. So that's pretty much all I have to say. So I'm going to hand it over again to Stephen. Thank you.
Give Daisy a clap, guys, come on. Now, you've all sat there very patiently and listened to all of us waffle on about how, you know, how awesome we are, about how we've implemented microsystems change in our own program. Now I want to give everyone out here a bit of a chance to, amongst your groups, there's only a couple of you on a table, it might be worth, you know, combining with another table, and have a bit of a discussion about how you can implement microsystems change and how the people on your table. So, you know, make it concrete, make it, I can do this. Pop it down on the paper, and then after you've had a bit of time to do that, we'll bring it back to the rest of the group and have a bit of a discussion about it. Because I guess what we really want to see from today is that everyone is able to go home and start something, no matter how small it is.
Oh, okay, I've got the microphone back again. Lots of really good conversations going on, I think. Looks like we have drawn some drawings over here. No, we're just going to see if we want to have a bit more of a chat. So who's got some really good ideas about things we can do to change the system in Tasmania? Everyone's having too much fun. Shall I start singing? La, la, la. I'm going to start singing. Time out. There's an alligator walking past the door out there. So, give us an idea. What's an idea? Who wants to give us an idea of something that we can take away today, put into our practice today? I'm going to steal the thunder over here because this was a really interesting conversation over here. And it starts about writing case notes. How many bloody times do I have to read, the writer went to the participant's house? My name is Corey, and I went to John's house. John was feeling pretty good today. John was feeling like crap. So we talked about the importance of using my name. Okay, we can get caught up in participant, we can get caught up in consumer, we can get caught up in client, but the one thing those three labels have in common is they're all attached to someone that actually has a name. So if we can take away an improvement of our practice around making it a bit more personal, because in a clinical mental health setting, it can be bloody impersonal. Love that idea. I don't know how practical sometimes that can be, but yeah, I think so. And it brings me on. I have this other bit of weirdness in my brain. I quite like quality and systems and process. It's pretty weird, and it's completely gone out of my head. But it's this idea of safety. If we start to look at safety, and this idea that all people with mental health issues are violent. Well, I'm a lot of things, but I'm never violent, ever. And when I meet someone else in the community for the first time, like I met this young lassie here on Monday, and I sat down and I thought, oh Jesus, you're from Devonport, my God. All right, so we need a safety management plan, darling. Yeah, what a load of rubbish. But the idea of it is sometimes we have to acknowledge that there are risks that are around, but let's name those risks with the people we work with. Hey mate, you told me you sleep with knives and a meat cleaver. That's sort of kind of a bit potentially concern and risk to us. But let's have a conversation with that person and say, I'm going to name it, I'm going to write it down, but how together do we get you to the place where you don't need to sleep with a knife? So use it as the opportunity to engage with the consumer, to talk about it, because together we can get a much better solution than if I sit down and write out a safety management plan. Well, okay, Kurt sleeps with knives, forks, all of these things. We're going to send 5 workers and we're going to have every meeting in the meeting room at McDonald's because it's video cameraed. You know, what a load of crock that is. So what other ideas have we got from the room?
So I was thinking just about unpacking, I think, this idea over here of, using people's names in case notes. Is there anyone who thinks in the room who is in a worker role who thinks that they might not be able to do that? Any barrier is going to be... Okay.
But why do they say not supposed to use a name? And why would using a name make it any less official when it goes to the coroner's court? Because that's what we've got to remember. Oh no, you got to get out. Clinicians are here. How did they get in?
I think the main thing is to say that that John states something. That's the only thing. So to me, it's the stating bit.
Yeah, so I guess that's a way around, you know, and I think addressing your concern of, you know, you can just write I then, or, you know, I think the client's name is probably the more important part of it because we're not making John a number, we're not making John a client, we're making John John. Yeah. And I think your thing of, you know, you can still write it, you can say John stated that, and in fact, still admissible in court.
From my experience, it's better to use John's actual words in my instance than what I. So that's what I do. I actually use states, blah, blah, blah.
Yeah.
And in court, there's no problem with that in court, from my experience. Not that I've been to court that often. So.
Heaven forbid we should listen to our consumers and record what their desires and their passions and their interests are. You know, I'd much rather, you know, I'd much rather fix you in a couple of goes. Yeah. Sit down, meet you today. I'll fix you next time. Well, what a load of rubbish that is too. So what else have we got? This table's got a whole lot of stuff. Do more on the ground, forming of relationships and communities.
Can you guys, say a little bit more about what you discussed as a table, and what some of the things were that you came up with? Does anyone want to speak about it? Yeah?
Please.
Yeah, we talked about sharing stories is very important as well. The other thing we were talking about was where is it? Getting participants to actually look further than their limitations. So basically leading them into the ability to actually look forward to the future rather than just sitting down and saying, well, this is my life. Just giving them that, stretching them that little bit extra and saying you can achieve. Imagine, yeah.
Imagine better. Help me imagine a place that's better than I am currently. Help me support me through that journey to a place that's better.
Yeah, and another one was to invite clinical workers to the mental health team reviews as well. So that was really good. And connecting with the GPs and the relationships between GPs and people as well.
Okay, great. So let's, because I, like to overthink things, let's break down one of these ones. The sharing stories. What might be an advantage of being able to share stories?
Trust and openness. I find if you're a peer support worker and you share a little bit of your life experience, they quite often feel relaxed and open and more talk more freely about their own experience and their own journey. Yeah,
so it's about, I've opened up a bit of myself. Let's build a relationship from here. Okay, so looking at the other, go.
Probably help reduce that your workload.
Yeah. So it equalises the relationship.
It makes it a mutual. We talk about mutuality in that space. I stand beside you. I tell you there's a hole. You're walking down the street and there's a hole coming up. And it's in front of you, but I'm going to watch you fall in that hole and I'm going to watch yourself get yourself out. But I'm still there beside you.
Can we get the mic up the back? Okay.
Sharing your story actually helps them to realise that you're not perfect.
Yeah, humanises you. Yep.
You're just like them.
Stops that othering thing that was talked about a lot yesterday. We're both just people. We've got two down here. Do you need a microphone? Yeah, let's get your microphone.
Oh, it's this clinician again. Bloody hell. They always like to get a bit of themselves across.
Thank you very much. Often when I was working in the inpatient unit, I I'll be talking to a person, they'd say, oh, so what's it like talking to a crazy guy? And I'd say, hey, you today, me tomorrow. Like,
Yeah.
I'd be very blunt. Like I say, just because you're here now doesn't mean I'm not going to be here
Yeah.
next year, you know.
Yeah, it's great. And again, it's that we're not that different. We're all
Absolutely.
just people here.
Yep.
And I think you had something as well.
All I wanted to say is that we all have a story, so a consumer can share their story, but it triggers off other people thinking, oh, well, I've done this, I've done that. So the whole equalises everything beautifully.
That brings me back to that point. Oh, did they just put that there? I think that, of this idea of micro change in my life. I hear a story. I realise, in fact, I'll give you a little story about how we can sometimes affect change in people's lives. I facilitate my recovery groups. Brilliant thing to do. I can't do it anymore though. I finish it and I always have the same issues come up and I have to go see my doctor and all that kind of stuff, but enough about me. Sitting there, we've got this guy, his name's, let's call him Rick, and Rick is probably nearly 60, and we're talking about preparing to get well. This idea of lapse, this idea of relapse, this idea of identifying the triggers that say to me, I think I'm getting unwell. And so Rick puts his hand up and says, oh yeah, I've got voices in my head all the time. And we're like, oh, okay. Have you talked to your clinician about that, mate? No. Oh, why is that? Oh, well, I've tried every medication. I've had every medication. And, oh, okay, so, you know, when was the last time you had a medication review? Oh, 7 years ago. It's like, oh, okay, Rick. So we talked to Rick about, you know, how to find the courage to tell the clinician that I've still got voices, can I have a medication review? It actually turns out the reason he didn't want a medication review is because all psychiatric medications make you fat. That's why he didn't. So as a group, we talked about this idea of if we needed to make a change in our life, and that one of those changes was a different med that stopped the symptoms, but you had to walk half an hour 3 times a week, how would that go for you? Oh, well, you know, that might be okay. So Rick went to see his doctor and got a referral for a Medicare 295 or whatever that thing is, and off he went and saw the psychiatrist and got a medication review. Come back 2 weeks later, had to miss a week, screwed him up a little bit for a wee while. Come back in 2 weeks' time and he said, oh, I don't have voices anymore. Just made a huge change. And that was a group of peers supporting someone, listening, yep, understand getting fat on medication, but negotiating that change with him in his life, that's system change for an individual on the smallest level. And if Rick can do it, maybe I can. Maybe I can change what's my reality at the moment. Maybe I can imagine better. So, sorry, that should have been a soapbox warning then.
So I guess we've all kind of seen this thing about how sharing stories can really lead to microsystems change. But I guess the overanalyzing part of my brain now goes, are there any barriers there? Is there anything that stops us from being able to share stories? Is it privacy? Is it confidentiality? Is it boundaries? Is it any of those words? Over here, yeah. Yeah.
Sprinkled everywhere, and as much as there's distance between us, it's a very small town.
So everyone knows everyone.
You have to be very careful with what you disclose about your personal life. Talks to that person. I've had my name mentioned in Smithton, which is 3 hours away, 2 hours away from Devonport, where I live. Someone's actually talked about me, that distance, not in a negative way. But
Yeah. I think it's a unique challenge to certainly regional areas, but particularly around Tasmania, because there are so many small towns. So, me being a city slicker, I probably don't have a great answer to that, because there's 4 million people in Melbourne. I don't really care if 10,000 of them know my story. I'll probably never meet them. But how can we still share stories without coming across that issue? Does anyone have any ideas? We've got two.
I think you need to just be mindful of those boundaries and keeping that relationship keeping the relationship real. Because there's been a few circumstances in the relationship between the support worker and the person needing support where those boundaries have been crossed over to almost be seen. This is a person coming into the home 3 days a week. That it's going to be a natural progression of developing a relationship because you're there so often. But the dependency it can create in becoming almost friendship-like, where I've had consumers adding them on Facebook as an example, because the boundaries being crossed between the support worker and the friend that comes into my home, and suddenly there's all these dramas because, it becomes a point of crossing over. And then that's no longer a healthy relationship.
But do you think we can challenge that? Because I don't disagree, and in my experience, when I have developed friendships with former participants, it's kind of gone bad. But why can't we be friends? Why can't we challenge that idea of being, just because you have an illness? I'm just playing the devil's advocate. Why can't we be friends? Why can't we manage that relationship on a personal level that's not about me having the power and you being in a subservient manner? And that's a conversation we have all the time, and I agree with you.
And I don't necessarily think that shifts the power. I think, a participant can still be fully empowered in the support that they have without crossing the boundaries to be having a relationship on Facebook and going to, social events together. But,
I could tell you some wicked stories, or wicked stories.
those lines being crossed. And then it set up a real precedent for distrust when support has been needed to actually introduce somebody new into the home as well, because they've been hurt by
So one thing, what about we could make some microsystem change about removing that power out of our relationship with the people we support?
I have students that I taught many years ago that are on Facebook now, but I gave it a little bit of space between being their trainer and then becoming their friend. Once they graduated, it was a little bit of time after that we, even though I had their contact details, I didn't contact them for a little while afterwards, and that was like, 10 years ago now, and I see just one of them on Facebook, but I think that we can make friends with some of our clients. We choose our friends anyway, so we choose out of our clients who we want to be friendlier with and who we don't. It's not about having a choice, having to be nice to all of them and be all of their friends, because some of them we will get on better with than others. And so I think that we need to kind of use really good judgment on the ones that we think are going to turn out to be great friends, and we fall out with friends as well, don't we? So they're just people, and we choose our friends, so why can we not choose our friends at some stage? Don't ask me when, I have no idea about that, but why can't we choose our friends out of the people that we work with as well? Yeah.
Just on that, what I think tends to make it difficult is that we know a whole lot of stuff about someone that friends don't normally know, about this idea of I helped you get this job, and I went to the council and I explained to the council about the illness and all this kind of stuff, and you took the council to court because you thought they were discriminating against you, but you still want to be my friend, but I hold all of this knowledge about other things, and that can be really hard to manage. That what I know about you when I want to be your friend, and that really is where the crux of the problem comes from. I can be a friend, but I have this professional stuff that I know about you, or I'm managing about you. How do I manage what I know against the fact that I actually just want to treat you as my mate and sit down and have a wine with you?
Okay.
Yeah, you're building in hopelessness.
So we'll take a couple more on this one, then we'll have to get onto the other two tables because we're actually surprisingly starting to run out of time on some of their systems changey ideas.
All I was going to say is, but if that person needs another service again, you're setting up the next worker that's in their life for failure. Because it'll be, hang on, you're not going out to the pub with me. What's your phone number and all of a sudden, you know.
But don't we set our own boundaries? But each of the relationships that we start with, we should be building those boundaries or setting my expectations of this. And I get that you've had an expectation of this other guy. Well, you know what? I don't like wine. I like beer.
Okay, so one more just over here quickly. Then we've got a.
Look, to bring it back to the original discussion around systems change. My personal view is I think it's problematic getting into that friendship space. Maybe a better option is to build and support and facilitate the development of natural supports around the person that will be ongoing, which will last long after we've left the situation, which, goes on after 5 p.m. at night. Yep. Because, for me, it gets to the issue about what is friendship. And a friend is someone that actually takes a phone call after 5 p.m. and is there through thick and thin. And when, I'm not in service delivery at the moment, but when I was, I couldn't live up to that, I couldn't take those phone calls at 5 p.m. That's why I never did it, better to develop the natural supports. Yeah. Absolutely. Yeah, self-sustaining. Yeah.
Did you want the microphone or you?
No. Well, probably two things. A, we shouldn't be building a dependency with the person we're working with. Like, we're there to teach them to stand on their own 2 feet and make their own friends and stuff like that. But if it gets to a point where, I've worked with people that I really feel very close to and stuff, but then I've had the conversation and our relationship becoming more like a friendship, so I will have to get another worker for you. So which would you prefer, me as your friend or me as your worker? So then it sort of lets them choose who they're friends with.
But maybe that's also a sign that you've done really good work and your journey out together is coming to an end. Yeah. And that's hard too, isn't it? Recognising when I've done my stuff with you.
There's a few ideas, I guess, have come out of that, but I think, we started on talking about sharing stories, and I think we're all so keen on that we grabbed it and ran with it, which is really good. Just looking at mindfulness of time, it'd be great to see what the last two tables, if they managed to brainstorm any fresh ideas, because we spent a lot of time unpacking the front two tables' ideas. So is there anything that anyone wants to share that they came up with from either of these back two tables? I reckon everyone can guess what's coming. What does everyone like about that idea? What would be some of the strengths of including people in those email conversations about them? Yeah, kinda. One at a time. Okay, so we're saying that we've got a way that we can be kinder, more transparent to the people that we're working with, and it'll be less work for us. That sounds pretty good.
Then you're also maybe helping that other services to microsystem as well.
Yeah,
They'll be like,
modelling.
hold on, that's the person's name in there. Oh, right, let's look
Yeah.
at
I can't say what I was actually going to say on the slide. Exactly.
Yeah.
That's
like
that
it.
idea of othering, isn't it? We were talking about, I had to write that down. I thought it was like, wow.
encouraging other services to be mindful of their own language as well. Because if you're including the person you're working with and if they have an intellectual disability or mental health issue or whatever, it's in language that's common that isn't clinical, that isn't going to create a barrier, additional one.
So there's a lot of stuff falling out of this. Is there any?
We haven't spent any money yet either.
So that is microsystems change, though. All right. Are there any barriers? Is there any reason why we couldn't do this, or any situations where it wouldn't be appropriate to include a person that we're working with in an email?
You might just have to give the other workers permission,
Very good point.
or CC if you want.
Yeah.
And
But asking everyone.
But you asked me. You included me. It's like the idea of I get myself quite offside because I'm a bit of a consumer, and the carers sit over there, and you get my PIR team together in a room full of 20 carers, and we'll just all quiver in the corner. But ask me if I want my family. That's all.
So, and I think and
Place where you can use that microsystems change. They're in a clinical review. They have no idea what the clinicians are talking about. Use common language. Don't use jargon. Yeah, and encourage them. And if someone says something, go, could you please rephrase that because I'm not sure that even I understood what you said there.
And I do think, back to your point, you've got to be really careful with the email thing. If you put a mental health care nurse from inner East Melbourne, email her and put a client's email in, oh my Lord, do you know about it? Because that's their organisational and operational rules.
So it's asking everyone. It's asking you can I think it's a pretty good policy of asking everyone who's going to be involved. So you might come up with an agreement that FAM's worker emails, the person is CC'd in on, but the psychiatrist isn't keen on that. He's got an organisational policy that he's not able to work around, or for whatever other reason, he's just not keen on it, she's just not keen on it. But you've had that conversation, and I think it's about continually asking. This idea of we don't ask once and then it's done, and it's like in 10 years' time we're assuming that you didn't want to be included in the emails 10 years ago because you didn't have email because it was 10 years ago. Do you want to be included now?
We had email 10 years ago, mate.
Conversation is that microsystems change. You asking the psychiatrist and then knocking you back. You've planted a seed. You've gone, hang on, there is a way I can work differently. All right, go to the back table.
Oh, consumer, carer, participant, all of those. Do you not like consumer? What would you prefer to be called? Yeah, Sandy. Yeah, but sometimes it's really hard to have conversations where we don't use those sort of de-identified words and we do. Oh, all of those things, and you can easily make an argument why consumer is a bad word, but you can make the same sort of arguments why it's actually potentially empowering. And I just look at it from, sometimes when I do these things and we get participant, we get client, we get patient, we get consumer, don't get too hung up on that maybe, but I think the important thing is to name me, give me a name.
So can we go that as maybe a person by person thing? You want to be called a person that we work with, someone else I work with wants to be called a consumer. So how about in those situations where maybe for privacy reasons we can't say someone's name, do we make a concerted effort to call them what they've identified that they want to be called?
We actually have people that change their name. Exactly. And we acknowledge that, and that is also emailed out to all,
Yep.
all the workers, and then it is actually changed on our computer system to their new name, and it's upheld.
Yeah, over. Yeah, yeah. But I guess it's in certain situations, obviously, if you're asking someone to search for someone in a database by a 10-digit number, then you don't get a lot of choice. But in situations like today, if I'm talking about someone that I work with in a story and they've given me their permission to share their story for the benefit of the group that I'm speaking to now, it's not a hard thing for me to say, what do you want to be called in front of the group? Do you want to be called John in front of the group as kind of a generic de-identified name? Do you want to be called consumer? Do you want to be called participant? Do you want to be called person? You know, it's individual. It's...
I was going to say empowering them, but we don't do that. It's me power. But that's what it is. It's them having the power to do what they want. So anything else from at the back table that you guys talked about? There was a lot of discussion. I was up there.
The only thing I'd say is I really liked one of the original points about demonstrated.
Yeah.
Yeah. Because like Corey, and I think at the end of the day, if that's the key issue in the law, if you can demonstrate to a clinical partner or whatever how we can make their job easier or help them achieve the outcomes they want to achieve with that person quicker and more efficiently, you're going to give them on the side. And consistent. Absolutely.
And that's how you get that systems change, because I can stand up here and I can preach and I can tell all you guys these are great ideas, but if I do that great idea in front of you and it works and I've demonstrated that value there, that's a much more powerful message.
Just to add to that, I think it's also about being aware we need to be open to learning from them.
Absolutely.
It's not just I'm here to teach you and I'll give role models to you, but also I want to hear what you've got to offer.
We have I didn't mention this before, but we have a reflective practice meeting once a month with the staff, the social workers, and with the other people, the
Job capacity assessors.
This is at Centrelink.
Centrelink, and they now once a month all get together and do reflective practice, so we're learning from each other.
As soon as you start thinking you've got all the answers, you stop learning.
And the other key to that is taking along cake.
Food, as simple as it sounds though, food is such a necessary thing sometimes. We took food along to a lot of our initial Centrelink presentations, all that kind of meetings, and it made the group come together. They all had a central place. We were eating, we were talking, and people opened up more than they probably would have if they were in a real clinical, row by row situation.
If you take a cake to one meeting, you can guarantee you're getting invited to the next one.
Yeah, you can guarantee more people at the next one.
Exactly. But it's about creating, I guess it's the general idea of creating an environment for collaboration. It's not everyone sit in a row and sit there and pretend to listen to me. It's like, let's sit down and let's have a chat over some food.
Very cool.
Yeah.
Just wanted there seemed to be quite a lot of interest about language and using language. There's a really fantastic resource that's produced by the Mental Health Coordinating Council in New South Wales that talks about recovery-orientated language or tired language. So the tired language is Johnny suffers, and there's miles and miles and miles of these really amazing examples that are not about blaming me for things.
One I was using before is, Johnny's manipulating the situation. Well, no, Johnny's not manipulating the situation. He is determined. He knows what he wants to get out of life, and he has ideas and drive.
And if we're going to start including people in emails, if we're going to start sharing stories, let's have language be a part of that people are actually going to want to hear and are going to feel comfortable with, so that you're not blaming and you're not, stigmatising.
All right, well, maybe we might wrap it up there, but thank you all for coming, and hopefully it wasn't too bad, because we only got asked to do this yesterday, so we sort of banged it together, but I hope each of us can take away just that one idea to affect some change on the micro level, and maybe in a year's time, if PIR is refunded and we're at another conference like this, we can all sit around and go, hey, look at what we achieved from this one micro systems change conversation. Just one thing, and each of us can take that away, and each of us can improve the lives can support the improved outcomes and support people to live the life they want to live. That's the key. Support me to live how I want to live. So thank you, everyone.